This is Willie Kemp. This is my second lecture on anemia. We'll cover some general mechanisms and differential diagnosis based upon those mechanisms. As I said, there are going to be 7 parts to the lectures on anemia. I'm breaking them up into probably 10, 15, 20-minute lectures. And once again, I'm a forensic pathologist, but I have a very strong interest in general and organ pathology, i.e. non-traumatic pathology, and I very much enjoy teaching medical students. And there are me and Dr. Hughes are websites, and also my things on Twitter, which I haven't been active on for a while, but I probably will start again, trying to support getting these lectures out and known. Once again, here are my disclaimers. Read these before you view the lecture, and if you disagree with any of the disclaimers, do not view the lecture. Thank you. There's third disclaimer, and also, once again, just in case you want to know about me, how I teach, my idea on teaching, everything like that, watch the introduction presentation. Here are the references again. I've already went through them, so I won't go through them on every one for the 7 part, but like I said, these to me are great, and I wish several would have been available when I was in medical school. So we're going to talk about the general mechanisms of anemia. First thing though, once again, here's a question, so read it. If you don't know the answer, that's perfectly fine. This is what allows you to pay attention to the lecture, kind of hone in on certain things, and then it helps retention, everything like that. And we'll go through at the end again. And I did know, sorry, I have that in there as units. I didn't fill that in, but question's the same. It's just for learning. It's not going to be on the USMLE. So general mechanisms of anemia. So basically there's 3 general mechanisms. You lose the blood, and that blood loss can be acute or chronic, like i.e. actually losing the blood, like it leaves your body. So acute blood loss, for example, from a stab wound or something like that, chronic blood loss, GI bleeding, things like that. But you can also have loss of blood through increased destruction of the red blood cells, or you can have decreased production of the red blood cells. So those are basically the 3 main mechanisms by which you can develop anemia. So with blood loss, and i.e. blood loss meaning loss of the blood, like the red blood cells, the plasma, everything within it, like actually fluid leaking out. It can be acute, like I said, or chronic. With chronic loss, obviously the acute loss, the person's probably going to know they're bleeding. They'll be bleeding from a stab wound. They will be, vomiting up bright red blood passing per rectum, things like that. They'll know it. With chronic loss, sometimes they may not know they're losing the blood, but over time, when they develop anemia, they can get the features of anemia. So fatigue, weakness, pallor. Some important points. Basically, you have to have acute loss of about 20% or more of your blood volume to lead to hypovolemic shock. So if a typical person has 5.5 liters, in general, it's around 2 liters of blood, a little less than that, 1.5, somewhere in there that the person can usually go into hypovolemic shock. But an interesting concept thing, and this is in Robinson, this actually has forensic implications. After the acute blood loss, the hemodilution that brings their hematocrit down. So when you're losing red blood cells and you're losing the plasma, you're losing an equal amount. So basically, it's like if you took a cup of orange juice and drained out half of it, the concentration of orange juice in the orange juice will be the same in both of the things, even though you have half as much now. But what happens is if you fill that cup back up to full, you're going to greatly dilute the orange juice. So same thing with blood. If you had a glass of blood and you took half of it out, both of your concentrations have the same concentration of red blood cells. But if you now take your glass that is half full of blood and dump in water, then that will dilute it. So actually, when somebody comes in and has acute blood loss, they may not actually have a decreased hemoglobin or hematocrit. It takes a while for the body to save up enough volume to get their volume back up, but those red blood cells can't be replaced as quickly as the volume does, and so they will hemodilute, and their hematocrit won't actually show the acute blood loss change for a couple days. So just kind of an interesting thing. Has forensic importance, but it actually is in Robbins explained that way. It's good. Okay, so one thing I've always liked doing is developing flowcharts like this. So when you're on rounds and people ask you, or when you're attending or things like that, you're trying to determine a differential diagnosis. If you can break down your process and go from most general to most specific, you can form a better differential diagnosis, and you can have an organized differential diagnosis. So I taught this at UND. That some of the students come back and say, oh yeah, the internal medicine doctors are teaching us too. And if I learned this from somebody, which I probably did, I have to give him credit, but I can't remember who exactly showed this to me. And Dr. Stern does this too, as far as like using set key signs or symptoms to help guide your differential. So with increased red blood cell destruction, that can be from things that are intrinsic to the red blood cell, i.e. the red blood cell itself, or extrinsic to the red blood cell. So if it's extrinsic to the red blood cell, it's usually either immune-mediated or non-immune mediated. If it's immune-mediated, it can be antibodies or it can be autoantibodies. If it's antibodies, that occurs in things like transfusion reactions, immune high drops. Autoantibodies are of the warm autoimmune or cold autoimmune hemolytic type. And we'll talk about these. Like I said, this is in the beginning just to give you an overall view of the different types of things that cause anemia, but we'll talk about each one specifically. If it's non-immune mediated, those can become infections. Malaria, babesiosis, infect the red blood cell and break it, so hemolysis. And then obstructions in the tiny vessels, so a microangiopathic hemolytic anemia, so something due to something like TTP, hemolytic uremic syndrome, DIC, and then also artificial heart valves. My understanding, the newer ones really don't, unless they're malfunctioning. It's the older ones that kind of did this. And so if I remember in medical school, there was a guy who had a heart valve. It was one of the really old ball. It was like a ball and cup. And it would go back and forth between that. And I can imagine squishing the red blood cells in there. Okay, if it's intrinsic to the red blood cell, that could be, you think about what makes the red blood cell. You have membrane, you have the hemoglobin, and you have enzymes that help it function. Okay, no nucleus or anything like that. So start with the membrane. They can be hereditary, so things like hereditary spherocytosis, hereditary elliptocytosis, and acquired, the paroxysmal nocturnal hemoglobinuria. You can have enzyme deficiencies. So I already briefly mentioned before, but glucose 6-phosphate dehydrogenase deficiency with bite cells. You can have abnormalities of the glycolytic enzymes, pyruvate kinase or hexokinase. And then you have abnormalities of hemoglobin. Either you can have defective hemoglobin itself. So sickle cell anemia is a defective hemoglobin. Hemoglobin C is a defective hemoglobin. There's a whole bunch of other ones. Or defective production of the hemoglobin, thalassemias. So you can see from this, if you start out with a very general anemia and go to the mechanism and then go here with increased red blood cell destruction, intrinsic or extrinsic. Intrinsic, think about the components of the red blood cell. Extrinsic, immune or non-immune, you can form a really broad differential diagnosis in an organized fashion. Okay, so this is my image for telling me I'm halfway through, so I think this one I'm doing better on for the lecture. So this is at the Billings Zoo. This is just a tiger sleeping. I think my wife was saying, oh, it'd be so nice to be able to go up and pet him, but I think it'd be a lot different if you're in there with him. Just very, very pretty animals. Okay, so we talked about blood loss. We talked about increased destruction. Then the other mechanism is decreased red blood cell production. So with this, either you can have a defective maturation of the red blood cells, or you can have loss of the bone marrow itself. So defective maturation of red blood cells could be from a defect of the stem cells, so something like an aplastic anemia, or, which affects all lines, red blood cells, platelets, white blood cells, or a pure red blood cell aplasia, which affects just red blood cells. You have a defect in DNA synthesis, so deficiencies of B12 and folate, or decreased erythropoietin, which can occur in renal failure since renal kidney produces it, or anemia of chronic disease, or defective hemoglobin production. We talked about defective hemoglobin, but we're talking about now defective hemoglobin production. So you can have a decreased heme synthesis in iron deficiency or sideroblastic, or decreased globin synthesis in the thalassemias. So you'll see here that thalassemias come up twice. They actually can cause anemia through increased destruction because they're an abnormal hemoglobin, but also decreased red blood cell production can occur. And then loss of bone marrow, you can either be a hematopoietic neoplasm or non-hematopoietic neoplasm. So with hematopoietic neoplasm, leukemia, possibly lymphoma, just kind of wipes out the bone marrow. And so it replaces all the normal hematopoietic cells, including the red blood cell precursors, with leukemic cells. And then non-hematopoietic neoplasms, metastatic neoplasms can go to the bone quite frequently. granulomatous process, some type of fibrosing, things like that. So it basically just wipes out the space where the red blood cells would form, and so you don't have a place for them to form, and so you'll have decreased production. Okay, so one important differential that we kind of touched on was hemolytic anemia. And so hemolytic anemia, because it can be either inside the vessel, intravascular, or extravascular, which can be very important in helping determine what the differential diagnosis is. And so you can do laboratory testing for that. So with extravascular hemolysis, the hemoglobin breaks down and you get unconjugated bilirubin, so they'll get a hyperbilirubinemia, and because of that, they can have jaundice. With intravascular, you're breaking down the red blood cells in the vessel, and so the hemoglobin will be in the blood, hemoglobinemia. It'll go into the urine, hemoglobinuria, and then you actually get the iron will get into the epithelial cells, be released in the urine, and you get urine hemosideruria. Now, I did see that actually you can see some degree of hemosideruria in extravascular hemolysis, although it's not the most characteristic, it seems like, and you can see hyperbilirubinemia in intravascular hemolysis. I think the important thing to always remember about medicine is that you learn like black and white in medical school oftentimes, but in the real world there's a lot of overlap. But yet, if you were to see urine hemosiderin, the most common one association would be intravascular hemolysis. In extravascular hemolysis, you start to get splenomegaly and bilirubin gallstones from the unconjugated bilirubin. Iron deficiency, you do not see that in extravascular hemolysis, but intravascular hemolysis you do, because you're obviously losing it in the urine. And both of them actually have a decreased haptoglobin. So with the question, so once again, pause the recording, answer the question, and then we'll go over it. Okay, a 34-year-old male presents to his family physician with complaints of fatigue and shortness of breath, but no chest pain when he exerts himself. The symptoms started about 1 week ago. Laboratory testing reveals a hemoglobin of 6.7 milligrams per deciliter, hematocrit of 19%, reticulocyte production index, or RPI, of 3.1, so elevated, haptoglobin of 19, sorry, I don't have the units, and low platelets. Of the following, which tests would be indicative that intravascular hemolysis had occurred? So the answer would be urine hemosiderin. And then here's the explanation I wrote up when I was creating the question, so you can see. But the one there that's most characteristic of intravascular hemolysis of the choice would be urine hemosiderin. So once again, my suggestion: pause the recording and reflect and say, okay, what are 5 things I learned, or what are 2 things that I learned from this lecture? And this is a really good way to kind of cement this material in your mind. Like I said, and make it stick. They talk about a medical student went from bottom of the class to top of the class using just this one technique. And I've started using it ever since I read that book and learned about it. This is the red panda at the Billings Zoo. He's hoping that you enjoyed the lecture. I hope you learned something about anemia, and this helps in your studies or however you're going to use the material. And thank you.